one of the other interesting ideas about immunotherapy is combining different drugs. There was a trial that we've seen parts of in terms of the results, which is called Checkmate 227, which is a very large study, quite complex, different parts to it. We saw earlier this year in April publication in the New England Journal of Medicine and a presentation at a big meeting called AACR, American Association for Cancer Research, where they showed some provocative but still somewhat preliminary evidence that patients who have a high tumor mutation burden in their tumor, which is about 44% of patients who have lots of individual mutations in their cancers, seem to get a benefit in terms of progression-free survival from a combination of Opdivo, Nivolumab, along with another immunotherapy that has some challenges in tolerating it, which is Yervoy or Ipilimumab. So this combination of Nivo-Ipi or Opdivo-Yervoy is one that we don't yet have an FDA approval for. We saw more data at ASCO 2018 suggesting that this might be a particularly strong option, or a combination of Opdivo with chemo could be beneficial for patients with low level of PD-L1 that's less than 1%, and maybe particularly good either the Nivo, Opdivo chemo or the Opdivo-Yervoy combination for patients with PD-L1 that is very low, but the high level of tumor mutation burden. Tumor mutation burden is not something we routinely test for or use in our treatments. So is this something that you are using now? And what would you say about, should it be exported for broad use in 2018 based on what we know?
Yeah, I view this kind of as coming attractions. I think we'll really see TMB once we've seen some survival data from the Opdivo-Yervoy combination. And if there is, and there's an approval for that regimen, I think tumor mutational burden will become a very important biomarker to test for, because about a third of patients who are PD-L1 negative may still have a high tumor mutational burden and benefit from an immunologic strategy alone. The other point to make is we've heard a lot about Yervoy and Opdivo and melanoma, but that dosing is very different in terms of the autoimmune side effects than what the regimen is utilized in the Checkmate 227 study in lung cancer patients. And so because it's a lower dose of Yervoy that's given less frequently, it tends to be a little more tolerable. And so if we see an overall survival benefit in this study for patients with a high tumor mutational burden, I think this is something that'll be an attractive option for a group of patients.
But at this point, without an improvement in overall survival, you would be more reserved about favoring it.
Absolutely. I think the other point to consider with tumor mutational burden is it describes why patients with EGFR and ALK rearrangements don't benefit as much from anti-PD-1 strategies. So if you have an EGFR, ALK, or one of the 5 other NCCN driver mutations, you tend to have a lower tumor mutational burden. And that actually biologically explains why these drugs aren't, the immunotherapy drugs aren't effective in those patients. If you have a smoking-related cancer, these have more mutations in them, and that's why you have a higher tumor mutational burden. But I think there's a lot of nuance in tumor mutational burden. So the first step is to prove that the drugs work for patients with high tumor mutational burden. The second point is, what is a high tumor mutational burden? There are different cutoffs, there are different assays, and so I think there's going to need to be a harmonization effort. If you look at Checkmate 227, they use a specific vendor's Foundation Medicine's assay with a tumor mutational burden cutoff of 10, which is different than the historical cutoff. As we're looking into other assays, blood-based assays, as one of your colleagues presented data at ASCO on, David Gandera, I think we're going to see more and more the need to harmonize these different testing platforms in order to deliver the most effective therapy for our patients.
And then one of the other challenges of tumor mutation burden, or TMB, is not just the differences of one test versus another, but the time it takes to get the results, the amount of tissue. Karen, what do you think?
Well, I think, first of all, until we see the overall survival data, I think TMB remains certainly experimental. I would say that, again, I want to break this down into the fact that for patients who have non-squamous histology to where we kind of TMBs are right along to the list of actionable mutations that we get. It's there, so it's great to have, and when you have it, you do use it, in my opinion. But that is not true for patients with squamous cell, to where we don't just order a Foundation Medicine assay. So I think that this is a real dilemma, because here again, the time is a factor, but I'm not so concerned about the time, because we're used to that time of being, 3 to 3 weeks or more. I don't think it's the right time, and certainly we want to always get better and get those times much shorter. It's still even hard for all patients to wait that long. Those that have non-squamous cyst, any patient getting these molecular tests, it's hard for them to wait. So there is a real focus on getting the turnaround time faster regardless, and I think that's going to be important. I think if we can look at the blood-based tests, maybe that could be a little bit faster. I think, again, we have to try to get these assays, whatever the assay is going to be, really should have a 7 to 10 day turnaround time. Right. So I think that TMB is interesting. I agree that there's a lot of things that go into TMB, and we want to make sure that we have a validated approach to TMB. But I would say there's probably, again, other assays coming down the pike as well.
One other thing that I think is worth bearing in mind in my interpretation is that the comparison to 2-drug chemo combination was in the study, but the world's moved on since then, and today we have positive trials with Keytruda alone or chemotherapy combined with Keytruda, and so practically speaking, I think we are really thinking about is the combination of Opdivo and Yervoy one that I would favor over a combination of chemo with Keytruda. Maybe for the narrow, it's about 16% of patients have high TMB and very low or negative PD-L1, it's less than 1%. That's a group where I think it might have a toehold, but I still think it's early days, and what it's fair to say is it was positive enough to keep our interest, but not necessarily enough to change our practice patterns.
Right, and remember, we don't have this information of TMB with any Keytruda or any Tecentriq trial. It could be that it's just as good.
Right.
So we really do need to understand how TMB acts in these other clinical trial scenarios. And that would be important.
Right, exactly. Is this specific to
Correct.
Opdivo or Opdivo Yervoy, or is this just a predictor of who's going to do well with whatever immunotherapy you're thinking about giving?
Right. But I do, again, and I know Sandip would comment on this as well, remember that these 2 drugs, Yervoy and Opdivo, work very differently. Right. They have different mechanisms of action on their ability to enhance our immune response, and that is important.
Yeah, they work in different points in the immune system.
Just like chemotherapy, platinum works differently than Alimta, differently than Taxol. So that part is important, and that is really why I think, again, we do see these, we typically have combination regimens because we're trying to play off of many different attack the tumor in many different ways.